Öncelikle herkese hoş geldiniz diyorum. Akşamın bu saatinde bizi dinlemek için geldiniz.
Welcome. Thank you for joining us at this session. It's very late in the evening. Today in this session, I will discuss distinguishing bipolar disorders from psychotic disorders in adolescents. There are a couple of important qualities of juvenile bipolar disorder. I will go through them briefly. First of all, we have to include the pre-adolescence period as well. It might be confused with ADHD. There's frequent confusion with other psychiatric disorders. There is strong association with aggression and suicide, trends to younger onset of major mood disorders or earlier suicide in these adolescents, and it has a more severe and longer course compared to adult onset. And there is also, it is also believed that this is the most prevalent idiopathic psychotic disorder. Before I move on to the gist of my talk, I would like to give you some more information. There's a Kerpelinian dichotomy. He said there are affective disorders and there are other disorders. So since then, to define all the etiological underlying etiologies and treatments, these have been considered to be separate diseases or disorders, and we still use this in today's classification systems. But let alone the classification system, some have also argued whether these are parts of the continuum rather than being two separate dichotomies. And their claim is that there's not a neat biological distinction between the two, because some cases have core symptoms for psychosis, for psychiatry, for schizophrenia, for example, or for bipolar disorder, and it's very easy to diagnose them. There's no problem with the diagnosis of these patients. But some other cases show symptoms for mood disorders and others at the same time. That is why things get a bit complicated. That's why we have this classification or nomenclature of schizoaffective disorders. Family studies also show us that both schizophrenia and bipolar disorder have genetic qualities. Some families have multiple cases of schizophrenia, consecutive cases that is. Some families have consecutive cases of bipolar disorder, and some families have psychosis, schizophrenia and bipolar in different sequences. Sometimes in the same generation you see schizophrenia and bipolar disease at the same time. Twin studies and the conclusions from these studies discuss whether there are susceptibility genes and endophenotypes towards schizophrenia and towards bipolar disorder. These endophenotypes are sometimes maybe more susceptible to schizophrenia, and sometimes they're more susceptible to BP. And sometimes the symptoms of these two diseases, it is claimed, can overlap. In 1982, McGuffin and colleagues found the Moseley triplets. These are triplets actually, and they're genetically identical. However, the psychiatric findings of these triplets are different. Two of them had a lifetime diagnosis of schizophrenia, and one had a lifetime diagnosis of bipolar disorder. This leads us to think whether the same genetic components lead to different disorders in different individuals. Taking up this idea, some researchers carried out genetic studies, and they found some candidate genes both for schizophrenia and bipolar. Neuroregulin, DISC1, and COMT and G72 are some candidate genes for both disorders, schizophrenia and bipolar. 22q and 13q, these two chromosomes, were identified with SNPs, for example, in other studies as well, or with different transferences as well. So what is claimed or what is argued is that it is not the diseases that are inherited from earlier generations, but it is the psychotic attributes that are inherited from earlier generations, from the ancestors. And this is not a very strange idea, because these are all synaptic proteins that are coded in these genes. Therefore, such a mechanism sounds also very rational. The advocates of the continuum hypothesis say that these diseases are all on the same line. On one end there's schizophrenia, on the other hand there's bipolar, and in between there are other cases, for example mixed psychosis. Mixed psychosis also has affective findings, affective symptoms, and these are also seen very commonly in our clinical practice. They have this three-dimensional scheme. Craddock, for example, came up with this scheme, and they claim that wherever on this axis the symptoms fall, the diagnosis also goes in that direction. And of course, we have to use this idea. We have to make this idea a part of our classification system, be it DSM or some other criteria. So let me say a couple of words about DSM, and especially DSM-5. DSM-5 did not remove the doubts about schizoaffective disorder. This wasn't very clear at the beginning, and now they say if psychotic symptoms occur exclusively during the mood episode, then let's call this mood disorder. It can be depressive or bipolar. In the definition of schizophrenia, DSM-5 says there should be no major mood episode during the active phase. However, if mood episode is present, then you have to look at the overall picture. That is, you have to look at the active and residual phase, and in the active and residual phases, if the mood episode is brief, then this can still be called schizophrenia. In schizoaffective disorder, major mood episodes should present for the minority of the total active and residual course of the illness. There might be psychotic symptoms, of course, in between, but a 2-week period of psychosis without prominent mood symptoms is needed for the diagnosis of schizoaffective disorder. How about early onset bipolar disorder with psychotic symptoms? We know that psychosis or psychotic symptoms are very common among adolescents. Studies show that this prevalence changes between 61 to 87%. It's important because it leads to poor inter-episodic functioning, poor recovery, or poor response to therapy, and it significantly increases the suicidal risk. There are other studies as well. For example, for bipolar 1. How do we differentiate bipolar 1 from other diseases? The more severe the manic symptoms, the greater the overall functional impairment, the higher the rate of hospitalization, and the higher the rate of suicide attempts. The closer we get to the diagnosis of bipolar 1. I'm sure you all heard of the Kobe study. In one of the arms of the Kobe study, the researchers looked at the correlation of psychotic symptoms and other significant associations. Bipolar 1, comorbid anxiety disorders, comorbid panic disorders, suicide attempts, family history of major depression, anxiety disorders, and suicide. So the researchers say that there might be a genetic liability internalizing this multiple susceptibility loci, because there is family history as well. So intermechanism disorders maybe go hand in hand with psychotic malignancy. Another parameter is the follow-up time. There are certain factors that extend or that prolong the follow-up time. Psychosis is one of them, for example. Mixed episode, low socioeconomic status, comorbid ADHD, conduct disorder, substance abuse, and family psychopathology are some other factors. Carson and colleagues carried out a study actually published a study in 2012. This was a 4-year follow-up study on cases that they saw during 1989. From 1989 until 1995. And they looked at the factors that worsen the course of the disease. The poorer the premorbid functioning, for example, the worse the course. Same goes for Schneiderian symptoms, greater depressive symptoms, and younger age of first hospitalization. These are found to be worse prognostic factors. As we all know, psychosis is an impairment in reality testing. It has certain components such as hallucinations, delusions, severe disturbances in cognition, and bizarre behavior. Of course, it all starts with mood disorders or schizoaffective disorders. These are also seen in schizophrenic disorders as well. So when we see a symptom, it can be in the form of an isolated symptom, isolated psychotic symptom. Of course, this leads us to take into account other options as well. For example, anxiety disorders. Anxiety disorders are very common in children and adolescents. Hallucinations after psychosis are mostly seen in anxiety disorders in children. Disruptive disorder, personality disorder, substance abuse, PTSD, seizures, and migraine are also other cases, other conditions during which we can see isolated symptoms. The most common psychotic symptom during adolescence is auditory hallucinations. We don't maybe see it in all adolescents, but I read it in an article. Children usually say that they hear noises coming from the inside of their head, and adolescents usually say they hear noises coming from the outside of their head, from outside their head. Maybe children cannot really formulate how they experience the hallucination, or maybe they cannot express themselves in a sophisticated way, and this has to do maybe lack of cognitive maturity in children. Let's have a look at hallucinations briefly. These hallucinations might be commenting on the subject's actions, thoughts, or feelings. They might be conversing about the subject, criticizing, insulting, or threatening the subject, speaking the subject's thoughts aloud, or sometimes they have a religious content as well. There are also non-diagnostic auditory hallucinations, such as footsteps, knocking, or hearing one's name being called without any other verbal hallucination. These should not be missed out as psychotic symptoms. Let's have a look at the delusional content. These might be in the form of delusions that match mood disorders or not. We have to have some idea about families' cultural beliefs, because sometimes what we call delusion can be a part of the cultural belief, and children with mental retardation sometimes cannot express themselves well, although they have a delusion, or they lead to overinterpret what is possibly not a delusion. Formal thought disorder is a problem with conceptualization, loosening in associations, and illogical thinking. Geller and colleagues developed Washer cassettes in 1998, and one of the items that they listed among thought disorders was pressured speech, because they thought that flight of ideas and racing thoughts seemed to correlate highly with pressured speech. and that can help us differentiate BPD from ADHD. Another study conducted by Pittsburgh Mood and Anxiety Disorders Clinic, they checked the psychiatric data for 2,031 children. They looked at the phenomenological data. I will go through this rapidly. Of course, the majority of the children were diagnosed with MDD, some with disruptive disorder, and then comes the anxiety disorder, and then bipolar. Schizophrenia scale diseases are not high in the list. Hallucinations were divided into three here. One group scores higher on hallucinations. Let's call this group definite psychosis. The mid-scoring group will be called probable psychosis, and then there is another group without any hallucinations or delusions. So of all this group, 4.5% of them were definite psychotics and 4.7% were probable psychotics. The rest didn't have any delusions or hallucinations. And then they looked at the distribution of diagnosis. Major depression turned out to be the number one diagnosis with a rate of 41%. Then comes BPD, and then come the depressive symptoms at a rate of 21%. Schizophrenia and schizoaffective disorder have very low rates, that is 14%. Anxiety disorders are very common at this clinic. Anxiety disorders and disruptive disorders are comorbid mood disorders, therefore they were added to that group. So they might have psychotic symptoms, but psychotic symptoms may also go hand in hand with mood disorders. Let's have a look at the breakdown of psychotic symptoms. Hallucinations at a rate of 80%, delusions 22%, and thought disorder 3.3%. Auditory hallucinations are prevalent in the whole group. This is again the group with definite psychosis, but probable psychotic group also had a similar breakdown. Delusions of reference were found to be high among all delusions, and thought disorder was seen at lower rates. Then they carried out a factor analysis on the definitely psychotic group, and they found 4 factors. These 4 factors explain 44% of the variance. These are hallucinations, thought disorder, delusions, and manic thought disorder. They use these factors to match them against the diagnosis this time, to see the association between the diagnoses and factors. And they find out that MDD, panic disorder, and generalized anxiety only match with factor 1, that is hallucinations. Bipolar, for example, and schizophrenic spectrum match all 4 factors. They're associated with all 4 factors. So in the end, they say that the strongest association is with schizophrenia spectrum disorders. But in the clinic, we mostly see mood disorder patients with psychotic symptoms. So their conclusion was the following. If there's incoherence, for example, then you might think of schizophrenia, but all the other delusions of reference, persecutory delusions, and all the others, these might be interpreted as bipolar disorder. So in an adolescent, if we see a psychotic manifestation with hallucinations and delusions, first we have to make a careful evaluation for mood disorders. There is a higher possibility of these patients being diagnosed with bipolar disorder. But how are we going to distinguish bipolar disorder from schizophrenia? There are several symptoms, of course, like the psychiatric history of the patient, consistent use of diagnostic criteria, but what really matters is follow-up. Some cases, of course, have a very clear episodic manifestation. You see grandiosity, for example, in the patient. That's clearly bipolar. But in all the other patients, you have to follow up the patient for a while to reach your final conclusion. This is another interesting bit of information. They checked the family history of schizophrenic children as well as bipolar children. And the schizophrenia group was found to have a family history of both affective disorder and schizophrenia. Bipolar disorder kids tend to have a more homotypic affective diathesis in their families. So if there is affective disorder in the family, be it depression, be it bipolar, then we might interpret it as bipolar. You have to wrap up. Okay, we have several algorithms that we have to keep in mind. Pavlouri's suggestion is as follows. Pavlouri says, first we have to clean our treatment protocol. And then, of course, mood stabilization has the priority. We have to stabilize the mood and then check other symptoms. If there are any other problematic areas, be it ADHD or other side effects, then we have to deal with them. We already know about the FDA-approved medications, but I still want to go through them. Risperidone, quetiapine, aripiprazole are indicated after age of 10, lithium after 12, and olanzapine after 13. For maintenance, aripiprazole and lithium are indicated. In treating bipolar disorder in adolescents, we know that a single mood stabilizer does not respond that well. Kafantaris carried out a study in 2001. The data is very important because the later guidelines were very much affected by the results of this study. This is a discontinuation study. First, the patients were given lithium and adjunctive antipsychotic together. Once lithium reaches a certain therapeutic plasma level, they discontinue the antipsychotic and they see a worsening of symptoms in 43% of the patients. Once they restart the antipsychotic, the symptoms are again relieved. So the guidelines say mood stabilizers should be combined with second generation antipsychotics. This will help you keep the dosage of antipsychotics lower. But the disadvantage is that you have to decide when to discontinue the mood stabilizer and you have to be sure of your diagnosis. Of course, with the new guidelines and with the advent of new drugs, atypical antipsychotics might turn out to be the first line of therapy as a standalone treatment. If the patient does not respond to therapy, you might discontinue antipsychotic and you might move to augmentation with classical antipsychotics. Well, this table is something that you can find everywhere, but I still want to go through it. Thank you.